Hello. Welcome to Kindly Neurodivergent with Kay. This show is to spend quality time with each other, kindly discussing the similarities and wide range of differences we experience. The experiences we discuss on this show are for educational purposes only. Please do not substitute for professional medical advice, diagnosis, or treatment. Before we begin, I respectfully request that if you witness any pauses during this show, please continue watching. I'm composing a spontaneous comment or question, someone's processing their thoughts, in addition to repeating something that was unintelligible or misunderstood. It is natural discourse, and we can choose not to say anything while this is occurring. Today I have a longtime friend of mine, Dr. Cordone. She is here to discuss what transformations emergency care needs to be accessible to everyone. We met each other through a peer mentoring program and were matched together from when I was in 5th grade through high school. Dr. Cordone is a board-certified emergency physician practicing in New Haven, Connecticut. During medical school, she also pursued additional training in public health, obtaining a master's degree in public health and graduate certificates in medical education and disability studies. In addition to working in the emergency department, Dr. Cordone is currently completing subspecialty fellowship training in pediatric emergency medicine. Welcome, Dr. Cordone.
Thank you. Thank you for having me.
Please introduce yourself.
Yes, so my name is Alexis Cordone. I'm here to talk about emergency care. Kayla, you should introduce yourself too.
I am Kayla Ireland. I have spastic quadriplegia cerebral palsy. My other diagnoses include epilepsy, which is a seizure disorder, and dysphagia, a swallowing disorder, along with movement disorders such as spasticity. Discuss the various types of disabilities, with a focus on neurodiversity.
Sure. So I think you know probably more about this than I do, but from my understanding as a physician, we can characterize disabilities in several ways. And so one way to look at them is by what they affect. So vision, movement, thinking, learning, memory, communication, hearing, mental health, social relationships. But we can also characterize them how they're acquired. So if it's due to genetics, due to developmental causes, due to environmental exposures, from an injury, or due to medical illness. And so maybe you can tell us a little bit more about your disabilities.
My disabilities were acquired at birth. With the assistance of a vacuum, I exited the womb and into the world as an unconscious, full-term baby. My pediatrician performed CPR to give me my first breath of air.
Yeah, so exactly. And that's a really good example. And some disabilities can also be characterized by whether they're progressive or intermittent. And so, for example, MS, multiple sclerosis, is a really good example of something that can be actually, and it can have on multiple courses. And so some people have progressive disease. Actually, most people, I think, to some extent have progressive disease, but others have a more intermittent course. And of course, it can vary on a whole spectrum. To get to your question about neurodiversity, I think that the term neurodiversity describes how people's different brains function, and that it's intended to be an empowering term to envelop the difference between how individuals think and process information without actually attaching a value to it or a judgment, or to assert that there's one correct way for how a person's brain should work. What do you think about the term neurodiversity?
I think the new term neurodivergent is unique. There's so much overlap between terms like adaptive, therapeutic, therapy, special, and regular exercise life.
Yeah, that's a really good way to think about it. So Um, I think another part of your question too about disorders and disabilities. So traditionally speaking,
What's the difference between disorder and disability?
yes, exactly. So traditionally speaking, I think disorders were thought of more in like a medical context. So disorder is more of a medical term. And so when I think about it, I think more about like a diagnosis or a medical condition. And generally, a disorder, the idea is that it leads to a difference in function for the when comparing to somebody who is more average or unaffected versus a disability. And disability is more of a functional term, so it more encapsulates the disadvantages that a person might experience in society. And so it's relative to the society that you live in, right? Like, for example, being deaf might be considered a disability in one society, but actually, if you go into another group of people and everyone is deaf or hearing is not how people interact with the world, then it's not really a disability, right? And so it's situationally, it's like situationally or contextually dependent.
Let's talk about some of the barriers that people who are neurodivergent face in the emergency department.
That's a really
Why
good
are
question.
healthcare environments cluttered with lack of space? Why are healthcare environments
I think that to get to this idea of crammed environments, this is so important in the emergency department, right? Like you've really hit the nail on the head. So, um, one of the problems that we face in the ER is that in many departments, our patient capacity is much larger than the physical space we have originally built to accommodate. And so I know definitely that is true of a few of the emergency departments that I work in or that I have worked in. Um, it's a great question. So I think it has to do with many, many factors. It's a very multifactorial problem. And so I think the biggest contributing factors, number one, are that um, the services that we're able to provide in the emergency department are actually growing and expanding, which is great. And so because of that, we have more ability to accommodate patients and more reasons that someone might come to the ER than maybe traditionally. And I think historically the idea behind the emergency department was it was where you go when you're having an emergency, but now we do all kinds of like fast track and urgent care and different things that maybe weren't available previously. And then we also have
example?
a good example, I think, of that would be, let's see, some emergency departments, for example, can do imaging that was not available back when maybe the department was built. And so having the ability to do that imaging is great, but also it adds time to people's visits and it also brings in more patients than we might have otherwise had, right? And so I know for a couple of the departments that I've worked in, one expanded maybe about like 15-ish years ago, and they're actually considering expanding again because in that short period of time, the volume of patients that we're seeing and the amount of time that they're in the department has actually increased. I think that's also another factor too, is that the amount of time people spend in our departments in the emergency department tends to be longer now because we can offer so many more services, right? Like back in the day, maybe you'd get an X-ray, but now we get X-rays, we get CAT scans. Occasionally, we even get MRIs, and those things take time, right? Yeah. And so by having more services that you can offer, it means that, we need the space to be able to accommodate more people. And so we also have more equipment than traditionally we might have had. And so we get more things. We have no place to put them. I know in the department that I work in, and we have a lot of patients being seen in hallway beds. And we all, as physicians, like I detest seeing patients in hallway beds because not that I don't want to see patients or that you can't provide medical care in a hallway bed, but it's so much harder to talk with people discreetly. There's so much more sensory stimulation. H, I, P, P, and HIPAA. Yes, HIPAA. HIPAA is a real problem. And so we actually have a team of staff members that um, is their job is to help protect patient confidentiality and enforce HIPAA. But when you're providing medical care in a hallway bed where other people can be walking through, that can be a real challenge. Um, I think in terms of other barriers that cause
How
a lot.
do we modify physical barriers such as lack of ramps, narrow doorways, and inaccessible medical equipment?
That's a good question too. So sometimes I think these things come down to um, whether or not we've had enough momentum to change, right? And so certain things in our environment are regulated by, actually many things in our hospital environment are regulated, to be honest. But I think with time, a lot of things that used to be the standard have changed, right? And so it takes time to catch up to that. And when you already have such a premium on space, it can be really hard to think about, well, where are we going to put a ramp? One of my least favorite things that I've noticed about ramps is you would think that they would be in the easiest location to access them, right? Like the shortest, most, most efficient route to get from point A to point B. That's where the ramp should be, really, right? Because probably people who need to use the ramp or who would want to use the ramp would like to get from point A to point B quickly, right? Yeah. But it seems like ramps are often added as an afterthought, right? And so, yeah, like the most circuitous route possible to get from point A to B, that's where you're going to find the ramp. This started becoming much more apparent to me when I'd go to family members' appointments in the hospital and things, and maybe wheelchair, and that's where I started to appreciate, man, this really doesn't make a lot of sense. And so we add these things in, right? But maybe they weren't there originally, and that can be really challenging. The narrow doorways, definitely. I think, thankfully, due to fire codes, a lot of our doorways in the ER are quite wide. And so that I think is maybe less of an issue than some of the office-based settings. But the medical equipment being inaccessible definitely is something that can be challenging, right? And so thinking about even some of the stuff we do, like in the emergency department, when we do slit lamp exams for the eyes, right? And somebody has to put their chin in a little cup and their forehead against it. That can be challenging for somebody with some spasticity. Yeah. And so and so thinking about alternative ways to get the information that we need and do a good exam, or how to make that exam feasible and doable. And we have some ways of approaching that. So, does that answer your question?
Help you.
What would help me? So I think generally when patients draw attention to things that are problems, that is helpful because we want to fix the problems, right? And a lot of times this is up to hospital administration. And so sometimes patients will tell me, hey, this, Dr. Cordone, this really isn't working. This isn't great. I have some feedback for you. And I say, that's awesome. But really, the people that need to hear this are the people who make decisions, right? And so we can always relay that feedback, but I think coming directly from patients and patient advocates and family members, that's where change really happens. So when there's a problem, I think going to the hospital administration, or whatever feedback mechanism that particular institution has, and relaying that feedback can be immensely helpful, because then somebody's drawn attention to an issue that people may not be aware is actually an issue.
Of course, this is important for everyone, but talk about the need for clear communication.
That's a great question. So I think for communication, and there's a lot of aspects to communication, right? So in the emergency department, one of the things that we struggle with is the background noise, right? There's a lot of background noise and a lot of distraction. And I think for people who are susceptible to sensory overload, it can be a very stimulating environment, and that can be really challenging. Yes. um, when we talk about having patients in hallway beds, some of my least favorite patients to have in hallway beds would be like elderly patients with Alzheimer's or something like that, because sometimes they can be very susceptible to sensory stimuli. And it's a very stimulating environment to be in a hallway. And then when you add boarding, hospital boarding to it, and people are waiting for 24 plus hours to get an admission bed, and they're just sitting in the hallway, that can be really, really disorienting for people. And so I think it's really,
Elopement 2.
sorry.
Elopement 2.
Yes, yes, exactly. Um, I think people also are inclined to elope when they're sitting in a bed for 24 hours waiting, you know, absolutely 100%. And patient satisfaction also gets low. And then when patient satisfaction gets low, sometimes the patient communication can be suboptimal because people are frustrated, and it's much harder, I think, for patients to express what they need when they're frustrated. And it's totally understandable, and we know how to work with that, right? But it presents a challenge for communication reciprocally because we want to have good communication when people are frustrated. It can be a barrier to that. Um, as far as other things, I think being really clear and direct about what people need, so not being sarcastic, trying to not use euphemisms. Again, sometimes we're doing this in the hallway and that can be challenging, right? You can imagine that I probably don't say, "Hey, do you use drugs?" like really loudly in the hallway, because that's probably not the way to ask that question, number one. And number two, that's not really the right context for that. Um, but it can be.
Communication is so complicated.
It is. Yes. And so I think depending on what patients' needs are, sometimes we'll do things like use visual aids, and we'll provide instructions written for like written discharge instructions for people, or even just written instructions in general. And I think we also try to accommodate by allowing people extra time to process information. And I think also one of the things that my hospital does really well that I'm super excited about is for patients who struggle to hear through background noise, or perhaps who patients who use hearing aids or other adaptive technology. We have FM systems available to help amplify. So I can use a little speaker and patients can wear a set of headphones, and then I can tell them what I need to say. And then this way we can both have a conversation, right? Um, and they can hear what I'm saying, but then they can also respond and tell me what they need, which is really helpful. Because it's one thing to be able to write notes back and forth, but it's a whole nother for people to be able to actually, say and hear. Exactly. And it also helps save time, which is huge because you can imagine running between emergencies. I get pulled away. I'll be talking with a patient, and then somebody will come in with a very, very life-threatening emergency, and I have to leave that patient. And so it's really important that we're as efficient as possible, but also we have to accommodate, right? So that can be a little bit of tension that people will have to grapple with when they work in this profession.
Please discuss how your electronic health record doesn't offer a spot for accommodations.
Yes, so this is a really good point, and I know we've talked about this quite a lot, you and I. One of my biggest frustrations is that we have so much bloat in our electronic health record. Like patients will tell me all the time, "Oh, Dr. Cordone, it's in my chart. Just read my record." And you know what, Kayla, somebody who is interacting with the medical establishment in any capacity more than a couple of times will have a chart, 7 miles long. And yeah, yeah, exactly. And so I think as emergency doctors, we're very good at getting the pertinent information very quickly out of the chart that we need to. But if you've never actually seen an electronic health record and how much information is there and how redundant it is, it takes a very long time to get good at picking through that information. And so one of my biggest frustrations with it is that it can be quite bloated, but also sometimes the information that I really desperately need is either nowhere to be found or not in any place that makes sense. And so an example of this that I think is very relevant is when we talk about um, how do people prefer to communicate, right? And where do I find this? Or eat? Yeah. Um, do they have dysphagia? Things like that. Those are all very good questions. And I would want to know that information relatively quickly when I am, in the task of caring for somebody in an emergency, and it can be really challenging to find. So even deciding, does this person make their own medical decisions, right? If somebody maybe uses sign language to communicate, how do I find that? We're very fortunate because we have a lot of patients in the hospital that I practice in where patients speak other languages than English. And so we have like an interpreter flag or a preferred language flag that comes up pretty obviously. So I'll see the patient's name, their date of birth, their age, their preferred language. And that's very visible to me. But if the accommodation So if the accommodation for communication is not another language, for example, American Sign Language, it's not there. So, for somebody who uses like an adaptive technology, some people use iPad software to communicate, um, or like even in this example, how you have prepped some of the responses and things that you want to, and the questions that you want to ask. That's not something that I can easily figure out for every patient in the electronic health record. It's not listed anywhere. Um, so that can be challenging. And what happens when somebody has, an emergency and they rush to the hospital and they don't bring the equipment that they may otherwise use? Um, I don't have a way to know that unless somebody brings it to my attention.
I wish my preferred language could be nonverbal communication.
That would be so helpful, right? Like if I could see that, because then I would know. So another example I think that you might appreciate is I've taken care of plenty of patients with CP, right? And CP is something that comes in spectrum, right? So yeah, and can affect different things, right? And so some people are very, 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 very verbal that I may not even know that they have cerebral palsy from just talking with them, right? If they're sitting down. And then other people might choose to communicate in different ways with adaptive technology. They might sign, they might do exactly, right? And how do I know that unless somebody tells me, right? I may have a very hard time figuring that out. And if a patient isn't in a position to tell me, meaning like they're having a stroke. I've had that happen. I've had patients with cerebral palsy have strokes, hmm Or a head injury or headache. Yep. Exactly. Um, then now maybe the patient is not in a position to be able to tell me because of whatever medical problem they're experiencing at that time, totally unrelated, right? To how they communicate. And maybe there's not somebody with them who can provide that context for me. It's just not necessarily always obvious. Now, we get pretty good at figuring these things out, right? Because we do this professionally, but it would be so much better, I think, for patients if there was a way to see this very easily in the electronic health record. So one of
If
the
anyone asks if someone has guardianship, we say no.
Mhm.
I prefer to do e-check-in online, so I sign my fancy canon.
So that's a really good example too, is for patients who have disabilities or for patients who are neurodivergent, where do I find out whether or not they make their own decisions? So we have a conservator flag. So if a patient is conserved, and this is a relatively new thing that only came out maybe within the last couple of years. So when I first started practicing medicine, it was not something that was so obvious. But we had such, and this is one of the things that I think came out of the feedback that we got is that patients who have a legal conservator assigned and need to be, that person needs to be updated about their care. We wouldn't even know that was the reality of the situation because unless somebody tells us, and patients will come in the middle of the night, and of course maybe their conservator isn't there. Sometimes people have a court-appointed attorney or something like that as their conservator, who may be conservator for many other patients as well. And so they're not going to come in the middle of the night and tell me, hey, by the way, please call me. Or tell me what's going on, right? And so knowing who makes medical decisions is really important. And so I'm glad that you brought that up as something that you have personally navigated, right? Where if you have the agency and the capacity to make your own medical decisions, and I think from interacting with you when you're feeling well, I think any of my colleagues would figure that out very quickly, right? Like we learn how to do this. But if you were not feeling well or you were unconscious or something like that, how would we figure this out, right? And so I think it can be really challenging for us, right? And so it's really helpful. Go ahead, sorry. Yes, exactly. And who wants to bring that up awkwardly, right? And damage the rapport that you establish. Um, I took care of one young man who I can't remember if he had cerebral palsy or what exactly, but he was there with his mom and his mom was talking quite a lot. And I eventually I just asked, do you make medical decisions or does he make medical decisions for himself? And he looked at me, and this was the first way he like the very first thing he communicated to me, and he just flipped me off. And that was his way. That was his
Oh,
way of telling me that he understood everything that I said, um, and that there was some tension between him and his mom.
ah,
I don't think he and his mom got along like as you and your
ah,
mom do, but I think he was a little bit frustrated with like
ah.
how she was so forward and upfront and kind of like taking over the interaction. And my failure was to, I guess, elicit this information a little bit sooner about how he wanted to address his own medical needs, right? Like when mom started talking, I just kind of went with it. And so if I had known that, and there was some easy way for me to figure that out, having not
Ah,
done it before, I could have mitigated that situation, right? And so then there was some
oh,
tension between the two of them, and I actually had to separate them a little bit so that I could get, more information from him because he was nonverbal too. Um, but actually communicates quite a lot. And I didn't have
ah,
a way to know that.
oh, one day.
Yeah, I hope one day. Yeah. um, it all ended up working out and everything, but I apologized. And I think eventually mom apologized to him and we all were okay. Um, but it would have just saved me a little bit of awkwardness and him a little bit of awkwardness, mom a little bit of awkwardness. So
especially in a true emergency.
exactly. We were fortunate in this particular instance that we had some time to figure it out. He wasn't there for something that was like acutely life-threatening, we need to know yesterday what was wrong type of situation. And so we had the time to smooth things over and figure it out. But it would have been so helpful to know that up front. Yeah. So I think
How
when
do you address tricky demands like lie still?
that's a good question. Um, I think it depends on the reason, right? Or like what the underlying necessity is. And so for certain things, like for example, during a neurologic exam, there are techniques we learn to modify our exam so that we can get the information that we need. And we do that for people with all kinds of disabilities too, right? Not just people who are neurodivergent. And so that's one way we can approach it. Sometimes, like for a procedure, um, we have other ways we can work around it. Sometimes it means medication that can help people relax. Sometimes that's not going to work. And so sometimes it means having somebody help hold something still. Like if we're doing a laceration repair or something and somebody needs to keep their arm still because they have a cut, we can have additional staff members come and help stabilize just so that that can be done. And also we learn, we just learn how to work with it, right? And so like, for example, maybe doing a laceration repair and somebody with tremors is not all that different from doing it on a toddler who doesn't sit still anyway, right? And so we have different ways we can approach that. And so I think we try to learn how to be flexible and accommodating. We sometimes fall short. That's why we're having this whole conversation, Kayla, is that there's a lot to be done, right? But we definitely try.
Explain empathy and understanding in providing accessible healthcare.
Ooh, this is a good question too. So um, I think it's really helpful for people to be empathetic when they have some context, right? And so for sometimes, like for example, I have a soft spot in my heart for patients with cerebral palsy, right? Because you and I are friends, and and so I can draw from some of the experiences that you have shared with me and try to help contextualize, maybe how some other patient that I'm caring for with cerebral palsy, maybe some of the things that they've experienced in the medical establishment that have not been very good, or some of the things they might be concerned about. Um, Not to say that everybody with cerebral palsy is the same. I think we've covered how it's a very vast spectrum of symptoms and experiences, and um, but I definitely think drawing on experiences that people have had can be really helpful. I also think that we try to be really understanding anyway. A lot of the patients that we see in the emergency department have disabilities. A lot of patients require us to be understanding. And sometimes patients don't have disabilities, or their disability is not part of what's um, making for a hard time for them that day, right? Like we might have patients we're caring for who are intoxicated, who need us to slow down so that they can process the information anyways, right? Totally independent of disability. And so I think we try really, really hard to be understanding and empathetic. Sometimes we fall short. And I think probably the largest barrier to that is the pressure that we're under to see people in life-threatening emergencies while also seeing people who may not be so emergently sick. And so, people can be very, very sick, but also not like in a time dependent, very emergent way. And somebody can have a very, very bad illness or a very significant problem that's causing them a lot of distress and suffering, but it may not be as urgent or emergent as some of the other patients that we're seeing. And so we get pulled away. Patient will come in, in cardiac arrest, and I have to step away. And that can be really challenging, right? So that sometimes is where we find our empathy and our understanding slipping, unfortunately, but we try.
For help.
And what would help? Yeah, so I think probably some of the things that help are things that probably are not realistic to ask for, right? Like, I guess maybe some systems have found ways to work around this, like a critical care shift where patients who are really critically ill are being seen by the same doctor, but that doctor can have the same problem, right? Where they can get pulled between two different patients or multiple
Yeah.
patients who are critically ill, right? So there's no perfect solution because we can't predict. We're not scheduling people in advance, right? And even when you schedule people in advance, like in a clinic or something, I'm sure there are plenty of scenarios where people come in with one problem and then they have something else that's also going on, right? And that can create time pressure. But our patients aren't scheduled in advance, and I don't know how many people are going to come in and what the level of acuity is going to be. So I'm not sure that there's a true solution to it. But I think making sure that the staff is minimizing burnout, right? Burnt out staff don't do a good job being empathetic and understanding. So that's a big thing. Making sure we're adequately staffed, making sure we have the resources that we need. And these are systems issues, right? So I think that can be really helpful so that we're in an environment where we have the tools available to us to provide medical care that is good. And then we can be empathetic and understanding. Because I think most people who go into healthcare generally want to be empathetic and understanding, right? People go into healthcare because they're like, oh man, I hate people. Guess I'm going to be a doctor. I don't know any of the doctors that I went to school with who felt that way, even if maybe, some doctors are not as empathetic and understanding as they should be, right? Yeah. So,
If a family member goes to a provider that won't be best for me, we avoid that provider.
and that's probably a good strategy, right? Yeah, the problem with being in the ER though is that people generally have a choice. Sometimes we do have a choice because we'll have multiple physicians in the same department, but generally that is, not the norm. So yeah, so if I'm a bad doctor, I'm sorry, you're kind of stuck. Yeah. Um,
How do you address the inaccurate, misinterpreted pain scale? Should the pain scale be omitted? If not, why?
pain scales. Okay, that's a very controversial topic. Yeah. So, being that I'm doing a pediatric fellowship, right, in pediatric emergency medicine, I talk to kids of all ages, right? And a and I also see adults too. So a child who is 2 or 3 years old and has not necessarily experienced many terrible things in their life wonderfully, right? That's great. May have a totally different pain scale or reference reference standard for what severe pain is, versus mild pain than, somebody who has had a lot of pain in their life and experienced many injuries and has a lot of experience, right, with pain. And so it's a very subjective scale. Um, I think that for patients, we have to take into context, what their experiences are with pain. The problem with that is that it introduces room for implicit bias. And I think especially patients with disabilities can be on the receiving end of that bias, unfortunately. Um, do you have any experiences that you want to share or can maybe give a good example of that?
I have a hard time explaining pain. One time before college, I couldn't get in with my primary pediatrician for an earache. I had to see one of the other doctors less familiar with my history. He was rude, said my ears looked fine, and she can't explain herself. He prescribed me an antibiotic, then finally looked at my chart and saw that I had TMJ. He recommended that I go see my dentist, and yes, it ended up being a TMJ flare.
Well, there you go. Rule one is look at the chart. Rule two is it would be so helpful if people could have that little flag that we were just talking about so that maybe he would have known that you do actually communicate quite a lot. But number three, that is crazy. I'm sorry. That's really frustrating. I think that's a good example of that bias that we're talking about, right?
As a young adult,
Mm-hmm. That's wild. Yeah. I think just to say too, oh, she can't explain herself, that's pretty lousy. I'm really disappointed to hear that. Unfortunately, that is definitely a reality that I am glad that we're having this conversation for, right? Is that um I think we talk about biases and things like that. Um, but we still have a long way to go in really unpacking and unraveling these biases, especially about patients with disabilities. um, when we talk about neurodivergence and communication and things like that too, um, sometimes we might say silly things that have value attached to them that are actually really harmful and not just silly like in a trivial way. They really do have consequences. So that's problematic.
emotionally too.
Mm-hmm. Yeah, and then we can be judgmental about, well, why did this person choose to seek medical care at this time? Or why did they wait for this to get so bad? Or why didn't they go see, whatever other person that they could have made an appointment with? Well, when people have bad experiences, this is what happens, right? So,
I don't like unfamiliar.
mhm, I could imagine. And I think
How you
I think much like you don't like unfamiliar, I think as a physician, I don't like unfamiliar either, right? Some aspects of my job are going to involve unfamiliarity because all of the patients that I'm meeting, very few of them I've met before. There are people who I have taken care of that will come back and things like that. But generally speaking, anything that can help me understand what a patient needs is going to help make the whole situation less unfamiliar and easier for us to navigate together. So I appreciate when things are very clear. I think it's really helpful when family members can be around and explain what's going on, or help give me pointers about, this is how, for example, this is how Kayla communicates. That's so helpful. I have a few examples of patients who are really, really good about this, and they'll bring in like a document that's very condensed, very easy to read with their diagnoses, their allergies, how they communicate, who their doctors are, that sort of thing. So the numbers that I would call to reach family, things like that. That's just so immensely helpful, right? And can I get a lot of that from the medical chart? Absolutely. Not all of it, but absolutely, I can get most of that information, right? And figure out how to find it. But it's so helpful to have it up front. And it also tells me what the patient's priorities are, because the patient has taken the time, or the patient's family has taken the time to compile this specific information. So I know this is important, right?
Why do we still have these issues if technology is advanced?
So that's a wonderful question. I would love to know the answer to that myself. I think that sometimes we assume that just because we have a technological approach, it's an advanced approach or a better approach. And that is not always the case. Um, Sometimes technology fails, right? And we have to work around that. So I did not practice medicine in the era of paper charts, but some of my colleagues have had that experience, and they'll tell you that some things were a lot easier, some things were a lot harder, right? For example, deciphering the chicken scratch that can be our handwriting. Probably that is a good thing that has come out of having an electronic health record, is not having to try to figure out what the various chicken scratches mean. But there are a lot of problems that have come out of having an electronic health record that's very rigid in what information can easily be included, and how it gets assembled, right? Because we can always add information. Like I can include whatever information I want. If I were to see you as a patient, I can write all about how you communicate and things. But unless somebody specifically reads my note, and why necessarily, right? They're not necessarily going to see that.
Mm.
Especially when somebody might have 3, 4, 500 notes, because you come to the ER, you get a note from the nurse, you get a note. If you're there long enough, you get a note from the next nurse on shift change, right? You might get an event update. You might get you'll get a doctor's note. We definitely should get a note from the physician, or whomever is the provider that sees you. And so that right there is 3, 4 notes, right? Just from one visit. So you imagine you go to the ER 10 times and now you have like 40 notes that somebody has to read through, plus whatever clinic notes and whoever other doctors you see. And then there's all these notes from secretaries of various clinics saying patient canceled the appointment and, things like that you have to dig through. Mm-hmm. Or F, O, L, L, follow up. Mm-hmm. Exactly. Yep. And so it can be a real bear to try to sort through some of these things. I would love to have a little bit more organization to communication plan. So one strategy that I thought about, or one solution that I thought about, is that a lot of hospital systems use software like Epic, and that's one of the ones that I'm most familiar with. Yeah, and Epic is really great. There's a lot of great things about it, but there's a feature that we have in some of the hospital systems that I am familiar with, where we can put a chart flag, and the flag kind of just lets us free type whatever. And sometimes people will use this for things that are not really helpful. Like I'll have patients' charts that I'll open, and there will be a flag from the clinic about patient, prior authorization denied or something like that. And is that note helpful to me? No. But generally, people will put information in there about like patients who struggle with aggressive behavior, so that we know to expect that, or not necessarily to expect it, but to anticipate it and to prepare for it. And so I think that's a really great place to put communication plans. It's not intuitive. I think people may not know to look there for it, but it's a good, easy place for people to find that information. But I really do think, like you said, adding for preferred, where we see preferred language or interpreter needed, or whatever, whatever language that the hospital system that one practices in chooses to display that information, having another banner below it for people, and how a person communicates would be really helpful, or accommodations that would benefit them.
Oh, how are move?
Hmm. Yeah, I imagine that it would be it would probably be less helpful in the outpatient setting where people generally see patients back like recurringly, and that information becomes apparent and then you know. But for somebody like me meeting somebody for the first time, it can be really helpful.
Mm.
Um, may I ask you what qualities you appreciate in a clinician or a physician and when you're looking for good medical care?
There are only two qualities I really look for: patience and understanding.
Those are probably good qualities.
No.
Hmm. That's a good question. I think,
Help me.
yeah, I think I think from patients, I mean, sometimes I have the experience of being a patient too, right? People don't always
Yeah.
realize that most doctors at some point in their lives are patients. Like we all, at the very least, theoretically, get physicals at some point and whatnot, or we go to the dentist, you know. And so I think patience and understanding are really good. And then in terms of qualities from patients, I think also patience and understanding are really good, right? Like one of my least favorite conversations to have with patients is to walk into the room or approach the hallway bed. And then the patient starts telling me about how terrible their experience has been so far, how they had to pay X dollars for parking, um, or somebody in, outside the hospital was asking them for money or like things that I have absolutely no control over. And then they tell me, the wait time is terrible. It took so long for you to come here and see me. And I find that so challenging, right? Because I feel terribly that people are having a bad experience, but also now we're having even less time to talk about the things that are important to you, right? To the patient. And because we're talking about everything else. And I have no control over the fact that, you may have had to pay for parking wherever you parked, or that somebody outside the hospital was bothering you or something. You know what I mean? And so I think um, patience and understanding from patients is really helpful too, because at the end of the day, what I want to do is get to a good place where we've provided good medical care, and the best way we're going to do that is by working together. And when we already start the interaction and somebody's not happy to begin with about things I can't control, I can't change that, right? Like I can't fix
Especially before you get pulled.
exactly. So I think it's really, really helpful. I don't mind when patients tell me, hey, this is frustrating, right? If we can move forward from that and do what we need to do, I don't mind. I understand it's frustrating. Let's talk about it. That's fine. But when that's the conversation we're going to have and it's, repetitive and that's where we spend the bulk of our time, it can be really, really hard for me to provide good medical care because now we're talking about other things that are not pertinent to what we need to talk about. And then say I get pulled away or something and all we've done is talk about the parking, that's really challenging. So I think it's really helpful for patients to be understanding too. I also think forgiving is helpful, right? I really appreciated, for example, the patient that I told you about earlier, where I botched the communication because I didn't really know up front, and mom kind of just came right in um, and steamrolled him a little bit. And I didn't really realize that that was what was happening. I appreciated the patient being really forgiving. And when I talked to him, he was like, "Oh no, this happens all the time." Okay, you know. Um,
Overall, I have had good experiences with medical care. I have three more that I want to bring up.
okay, tell us.
We left an understaffed neurologist's office. We avoid generic Keppra as one time I ironically had a seizure around the time of having generic Keppra. Once mom was trying to juggle pushing my wheelchair and walker in the parking garage, etc. My wheelchair tipped over due to chunks of concrete missing in the walkway, landing in a puddle. The only thing that I struggled with and have to revisit, due to being physically uncomfortable, is the gynecologist. It has nothing to do with the provider.
Mm, that makes sense. I can just picture your mom like masterfully juggling the walker and the wheelchair at the same time in a way that probably most of us cannot do. One of the epitomes of trust for an ER doctor is when a patient who has a very, very nice wheelchair that I know, like in your case, after having, what you've told me you went through to get your per mobile chair up and running and like, all of the things that you were hoping for it to have, all of those features and that whole process. One of the epitomes of trust is when a patient tells me, "Oh, it's okay. You can move my chair," right? And they tell me how to do it because they're in the bed and they're not able to at that moment. Um, sometimes patients will tell me, "Do not touch it." you know, I can really tell somebody trusts me when they tell me I'm allowed to move their chair.
Yeah.
you know,
Yeah. Oh.
yeah. Especially knowing what you went through to get yours and fix it. And my goodness. And I'm like so afraid to touch it too because I know, I'm going to back it into a wall or something.
Yeah.
But yeah, I can just picture your mom. She's a master of this in ways, you know, that's just really unfortunate that there were those chunks of concrete missing. That's probably another barrier we can talk about another time is, when things are broken, do they get fixed?
No.
Not always, huh? Um, I'm curious to ask you too about other experiences or strategies that you think might make the emergency department more accessible, or if you have any suggestions for me. Just
More.
more what we talked about. Yeah. Oh, I like eating. Oh, that's a good thing to talk about too, is sometimes I don't know if patients have dysphagia, right? Like if they have any trouble swallowing. Um, And so we have different, we call them dysphagia diets, and that's probably not the best terminology to use.
No. No.
Um, so meaning like for patients with, there's many reasons one could have dysphagia, right? Many medical reasons and many types of dysphagia that I don't necessarily know we need to dig into the details of, but there are different ways to accommodate, right? And so some patients will have like a totally pureed diet. And so all of their nutrients, their proteins, everything will be pureed because that's what they're able to swallow comfortably. And we have to make sure they're getting their nutrients. Other patients, it's just certain foods. So like bread, I think bread is something, yeah. um, and so um, one of the things that we do is if we suspect that somebody has dysphagia, we'll do a bedside swallow screening with the nurse where the nurse will have them um, swallow basically, sometimes it's just water. But it's a very subjective thing, right? And so
I
knowing
have a hard time
Mhm. What do you tell people? Like when if let's pretend hypothetically you were in the ER, how would you approach that?
No. No.
Yeah. Um, mhm. Yeah, it's hard, I think, for patients. Also, sometimes, for example, a common scenario where I might encounter somebody with dysphagia is somebody who's had a stroke. I had this type of scenario maybe 2 weeks ago with where a patient came in and she had had a stroke, and part of the symptoms that she has as her stroke is that she's struggles with um, understanding her like she has a conservator now because of the stroke and her capacity to make decisions, but she doesn't always understand the consequences now of her actions. And so she really likes to eat, but she aspirates her food. And so she will ask the staff for food, even though she's really not supposed to be eating food. So she has a G tube, and that's how she's supposed to receive like feeds. But she'll ask for food, and because you wouldn't realize that she had a stroke unless you knew and that she had dysphagia, and because she's otherwise like very conversant and doesn't have like some of the other things that people think about with a stroke, like unilateral weakness or something like that. People may not realize that this is how her stroke affected her, and so she'll ask for food. And so we had to like intercept staff members who were trying to accommodate, her requests for food and bring her things to eat. But we don't have a good way to flag that, oh, she has dysphagia. So we can put in a diet order for like a dysphagia diet, and then many people will know, but it's not so obvious until we've figured that out. So sometimes it will be listed in
How
medical
do you deal with
problem,
people who don't have convertship yet?
conservatorship yet. Like S T
Oh,
R, like a stroke.
oh,
Or yeah, so people will come in having a stroke, right? And maybe they had capacity to make decisions and now they don't, and it's a very acute change. And so usually what we do is we assess for capacity. That's something that we're trained to do. And so for example, I'll give you a quick example. One of the things that somebody has to be able to do to have capacity is to understand the consequences of their decision. And so if you tell me, I don't want this treatment, it can't just be because I don't feel like having this treatment. It has to be, um, I understand what the reasons for this treatment are and what the consequences of not getting the treatment are, and what the alternatives, that we can approach are versus, no, I don't want that, or I don't like the idea of that. And sometimes, people will react to something that they don't want because it means, getting an IV or something like that. But they don't actually understand why that treatment is important, and that person doesn't really have capacity, right?
mm,
And so what we usually do is we'll defer to next of kin. And so there's a very strict way that we determine who is next of kin, unless somebody has been assigned like a healthcare proxy or something like that. So they may not have a conservator, but they have like a surrogate decision maker that they've delegated in the event that they weren't able to make their decisions.
oh, oh, if no one,
Yeah. So if there's no one, so what if there's no one? If there's no one, like no next of kin at all, you mean? F.
uh,
Okay. No family. Yeah. In
uh,
that L, I, like
if
if you
the,
didn't
uh,
have
I was born,
anyone. Yeah. Really good question. So in that case, what we typically do is we try to make a decision in the patient's best interests until we can identify who that person might be. And if there's truly nobody, I mean, some people, you're right, some people truly do not have somebody that, we can reasonably find or contact. And in that case, we do what we think is our best judgment and what we think most people would want, right? And sometimes we're wrong, for that particular patient. They may not actually have wanted that. But usually we do what the standard of care is and what we think they would have wanted based on, if they have like a living will or something like that. But E, S, P, especially
if
if T, H, they,
no,
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 don't,
or
always, G, O, go,
here,
you go right in. Yeah, exactly. So that's the other thing too, is people will use like multiple hospital systems. And
uh,
yeah. And so, we actually in Connecticut, as of the beginning of the year, we have a new system to help connect all of our electronic health records. And this didn't come out till this year, right? Before we had something called Care Everywhere, and we still have that, but I couldn't see everybody's notes. And this year, I'm able to see many more notes than I was able to see previously, but I still can't see a lot of notes, right? Like, because certain electronic health records, they're just not, the software's not built to talk. It would be like expecting Microsoft Word and Apple Notes or Apple Pages, right? To be able to access the same documents stored on two different computers, right? Not in a cloud. So I might be able to pull up something that was written in Microsoft Word on Apple Pages or vice versa if they're stored in the same place, but stored on two totally different computers or two totally different, systems, I can't actually access those notes. And that's so confusing to patients, right? Like they'll tell me, just look in the medical record. Well, I may not be able to see your primary care doctor's notes. I may not be able to see your notes from whatever specialist you might be seeing because they may not be on Epic or they might be on some other system that I can't access. And so I still can't access a lot of systems, but I can access more now than I was able to last year. So if you go through all of this trouble of getting your documents uploaded and everything, squared away at one hospital, and then you're on vacation somewhere else and have a medical emergency and come see me because, maybe you're on vacation here and I can't see any of that stuff, that can be really challenging. Again, we work with it and we figure it out. Like this is what we do professionally, but it can be a challenge.
How can we train hospital staff regarding the importance of disability awareness and sensitivity?
Oh, that's a really good question. I actually want to hear your thoughts on this, but my thoughts are, we get trained on a lot of things, right? And we get some education on implicit bias. I think that's a really natural opportunity to talk about disabilities and neurodivergence. And I think that, it has to be part of our curriculum, even pre-professionally, right? Like in medical school, nursing school, pharmacy school, we should be talking about this. And we do to some extent, right? But I think we could always use more and more targeted information too. I think also on the job training is important, right? And so one of the things that we do for like medical knowledge is we'll present cases. Like for example, somebody has an unusual presentation of a heart attack, right? We'll have like a conference about it and we'll talk about, this is how the patient presented and this is what was unusual about it. And maybe this is why it was really hard to figure out that that's what was going on. I'm giving a little bit of an oversimplified example, but I think talking about accommodations and disability awareness as part of a case presentation can be really helpful. I know I've been to some really effective trainings where patients with disabilities have come back and told us about their experiences, and I've really liked that. And because things that I wouldn't even think about, right? Because that's not been my experience, right? Can be really helpful just to have those conversations in like a non-pressured environment where I'm not seeing other patients at the same time and trying to navigate other things. And we have the time to sit down and talk and I can ask questions about it. That can be really helpful, I think.
I think it should touch upon it every month or whatever.
Mm-hmm. I think I think you're right. I think it needs to be like regularly reinforced because to have like, for example, a lecture on cerebral palsy during medical school, um, you know, I went to medical school. If we're talking about the first year of medical school, that was over 10 years ago for me, right? So like one hour lecture 10 years ago, how much am I going to retain from that if it's not being reinforced on a regular basis? Definitely, I need to have the lecture, so I have the prerequisite knowledge, and at least at some point, this information is not new to me, but I think reinforcing it over time is really helpful. And so I agree with you, it needs to be recurring. I don't know the timing and I don't necessarily know the format, but I think there's some pretty good evidence in the medical education literature about what types of interventions are more effective than others. And I think something that's recurring, something that's like simulation or case-based would be really great.
Even if it was just communication reminder discuss.
I agree. Sometimes we'll have like in-service meetings, that sort of thing, or nursing huddle. Those are good times, I think, to just, briefly review or like morning report. Sometimes it's only 10 minutes long, right? But it's a good time to just remind people, hey, this is a good thing to think about, or we had this case last week and we got feedback. You know, that can be really helpful way to reinforce that. But it depends on what needs to be reinforced, right? Like remembering to be sensitive and things that people kind of already know is good for those little reminders, but really teaching these topics initially um, obviously requires more dedicated preparation and investment.
Thank you, Dr. Cordone, for doing this with me. It was great to have you on. Please share this talk show with your family, friends, and colleagues. Everyone watching, don't forget to like, follow, subscribe, and share on Facebook, Instagram, and YouTube.
Thank you for having me.